Welcome to our third and last video on obstructive lung diseases. Let's begin. In this lecture, we will discuss cystic fibrosis and primary ciliary dyskinesia. Let's start with cystic fibrosis. In this subsection, we will discuss the genetics, pathophysiology, clinical presentation, diagnosis, and management of cystic fibrosis. Cystic fibrosis is an autosomal recessive disease caused by a CFTR gene mutation on chromosome 7. CFTR stands for cystic fibrosis transmembrane conductance regulator. The most common mutation in the CFTR gene is the deletion of a phenylalanine codon at position 508. Cystic fibrosis is characterized by allelic heterogeneity. In other words, many mutations of the CFTR gene can create deleterious alleles causing cystic fibrosis. It's worth noting that sometimes people with cystic fibrosis have different degrees of disease severity. This is why cystic fibrosis is also said to have variable expressivity. It is the most common lethal genetic disease in people of European ancestry. Let's talk about pathophysiology of cystic fibrosis now. Cystic fibrosis affects the lungs, gastrointestinal, and reproductive tracts. Let's discuss the pathophysiology in detail using an illustration. The CFTR gene encodes for an ATP-gated chloride channel that secretes chloride in lungs and gastrointestinal tract, while it absorbs chloride in sweat glands. Mutations in the CFTR gene causes misfolding and retention of CFTR protein inside the rough endoplasmic reticulum. Therefore, there is decreased chloride secretion in the lungs and gastrointestinal tract, while there is decreased chloride absorption in sweat glands. Reduced chloride secretion induces excessive sodium and water absorption from the pulmonary and GI lumina, making mucus very thick. Thick mucus obstructs the ducts, predisposing the patient to conditions like recurrent lung infections, pancreatic insufficiency, biliary cirrhosis, and so on. On the other hand, reduced chloride absorption in the sweat glands causes excessive sodium chloride and water loss in sweat. Let's discuss the clinical presentation of cystic fibrosis now. Cystic fibrosis patients have recurrent lung infections due to thick pulmonary mucus impairing the mucociliary clearance of bacteria. Staphylococcus aureus is the most common pathogen causing lung infections in cystic fibrosis patients less than 20 years old, while Pseudomonas aeruginosa is the most common pathogen in cystic fibrosis patients more than 20 years old. Recurrent pulmonary infections can result in bronchiectasis. The patients are also at risk for allergic bronchopulmonary aspergillosis. Cystic fibrosis is also characterized by pancreatic insufficiency due to clogging of the pancreatic ducts by thick mucus. This causes steatorrhea and fat-soluble vitamin deficiencies due to inability of the lipase to reach the luminal fat. Pancreatic inflammation can damage the islets of Langerhans, resulting in cystic fibrosis-related type 1 diabetes mellitus. Thick mucus in the biliary tree causes backflow of bile in the liver and gradual secondary biliary cirrhosis. Newborns with cystic fibrosis commonly present with meconium ileus. Meconium ileus is thick stool obstructing small intestine of the baby with cystic fibrosis. Finally, male patients with cystic fibrosis are commonly infertile due to congenital bilateral absence of vas deferens. In contrast, females with cystic fibrosis are often subfertile. The reasons for subfertility in women include thick cervical mucus impairing sperm penetration and amenorrhea due to malnutrition-induced hypothalamic dysfunction. Moving on, let's discuss the diagnosis of cystic fibrosis. The first-line diagnostic test is the sweat chloride measurement in a pilocarpine-induced sweat test. Pilocarpine normally increases sweat production. Due to decreased chloride absorption in the sweat glands, one can expect the sweat chloride concentration to be more than 60 in patients with cystic fibrosis. If the sweat test result is inconclusive, with a sweat chloride concentration between 35 to 60 millimoles per liter, we can measure the nasal transepithelial potential difference. Chloride retention within the epithelial cells and the intracellular shift of sodium increases the negative transepithelial potential difference. In newborns, we can measure immunoreactive trypsinogen in blood, which is released from obstructed pancreatic ducts. Finally, we perform genetic testing for CFTR gene mutation for confirmation. However, it is not absolutely necessary to diagnose cystic fibrosis. A 5-year-old boy is brought to the physician due to recurrent lung infections. He has been hospitalized 5 times due to lobar pneumonia in the last year. He also has chronic diarrhea and his stools are difficult to flush. The patient was born at 39 weeks of gestation and he did not have a bowel movement in the first 48 hours. Enema was needed to remove the inspissated stool from the terminal ileum. Cystic fibrosis neonatal screening test was negative. Pilocarpine-induced sweat is collected, and it shows the sweat chloride concentration of 50. What is the best next step in the management of this patient? This patient presents with recurrent lung infections, steatorrhea, and a history of meconium ileus. All these findings are consistent with the diagnosis of cystic fibrosis. Although the cystic fibrosis neonatal screening test was negative, it does not rule out this diagnosis because neonatal screening tests check only for the most common mutations of the CFTR gene. A pilocarpine-induced sweat test shows a chloride concentration of 50 millimoles per liter. When sweat chloride is more than 60, then cystic fibrosis is diagnosed. However, when sweat chloride is from 35 to 60, sweat test is considered inconclusive. The best next step in the management of the patient with an inconclusive sweat chloride test is to measure the nasal transepithelial potential difference. We will finish off discussing cystic fibrosis by talking about management. Treatment is multifactorial. It involves chest physiotherapy to expectorate the sputum. Albuterol is used to dilate the bronchi and helps with normal oxygenation. Aerosolized Dornase alpha is a DNase that breaks down the DNA of inflammatory cells in the sputum and liquefies the mucus. Inhaled hypertonic saline draws the water from the respiratory cells to the bronchial lumen, facilitating expectoration of sputum. Antibiotics are also administered for any respiratory infections. Ibuprofen can also be used to slow progression of cystic fibrosis. Azithromycin is used as an anti-inflammatory agent. Patients with cystic fibrosis may also require pancreatic enzyme replacement due to pancreatic insufficiency. Finally, cystic fibrosis patients with phenylalanine 508 deletion can benefit from the combination of lumacaftor or tezacaftor and ivacaftor. Lumacaftor and tezacaftor correct the misfolded CFTR protein in rough endoplasmic reticulum and facilitate its transport to plasma membrane. Ivacaftor, on the other hand, opens the CFTR channels in the plasma membrane and increases chloride conductance. Here's an image showing the mechanisms of action of lumacaftor, tezacaftor, and ivacaftor. As we already discussed on the previous slide, lumacaftor and tezacaftor correct the misfolded CFTR protein in the rough endoplasmic reticulum and facilitate its transport to plasma membrane, while ivacaftor increases chloride conductance. Finally, we will talk about primary ciliary dyskinesia or Cartagener syndrome. In this subsection, we will discuss the genetics, pathophysiology, clinical presentation, diagnosis, and management of primary ciliary dyskinesia. Primary ciliary dyskinesia, or Cartagener syndrome, is an autosomal recessive disease. It is due to a defect in the axonal dynein gene. Axonal dynein is an ATPase necessary for sliding of microtubules along each other in the cilia. Dysfunctional dynein therefore causes immotile cilia. Let's talk about pathophysiology of Cartagener syndrome now. Immotile cilia results in the defective migration and orientation of organs. This process in turn results in situs inversus with or without dextrocardia. Situs inversus means inverted sites or organs. For example, these patients might have the liver on their left and the spleen on their right. Dextrocardia means that the heart is displaced to the right side. Additionally, dysfunctional eustachian tube cilia can cause hearing loss. The impairment of respiratory cilia decreases mucociliary clearance of pulmonary bacteria and results in recurrent pulmonary infections and bronchiectasis. Finally, immotile spermatozoa in men causes infertility, while immotile cilia in fallopian tubes results in reduced fertility in women. The reason why women are not completely infertile is that the transport of egg is still possible from the ovary all the way down to the uterus via smooth muscle contractions of the fallopian tube. Here's a chest X-ray image showing dextrocardia in a patient with primary ciliary dyskinesia. Please note that the cardiac apex is on the right side rather than on the left. It's important to confirm the orientation of an X-ray before diagnosing dextrocardia. In order to do this, we need to take a look at this R sign, indicating the patient's right side. This is a CT scan of the patient with primary ciliary dyskinesia. Please note that the spleen is on the right side, while the liver is on the left. This presentation is consistent with situs inversus. Primary ciliary dyskinesia results in situs inversus with or without dextrocardia, hearing loss, recurrent pulmonary infections, bronchiectasis, infertility in men, and reduced fertility in women. We explained the pathophysiology of each of these conditions on the previous slides. Many of these clinical features are very similar to cystic fibrosis. However, a key differentiating factor between the two is that primary ciliary dyskinesia will not have any impact on the gastrointestinal system. Additionally, since these patients have no malabsorption, they do not have failure to thrive, in contrast to patients with cystic fibrosis. Let's talk about the diagnosis of primary ciliary dyskinesia. One can check the nasal nitric oxide levels as a screening test. In primary ciliary dyskinesia, the nasal nitric oxide levels are usually decreased. Chest X-ray can be performed to document dextrocardia. Chest CT scan will help visualize the bronchiectasis. Abdominal CT or ultrasound will visualize the situs inversus. Finally, genetic testing can be performed for Dinian arm mutation, but it is not routinely done. Management of primary ciliary dyskinesia is focused on alleviating the resultant complications rather than on curing the disease itself. Antibiotics are used for recurrent upper and lower respiratory infections. Assisted reproduction technologies can be used for conception. This is a table comparing and contrasting cystic fibrosis and primary ciliary dyskinesia. Pause the video and take a moment to consider the similarities and differences between these two conditions. A 25-year-old man comes to the physician because he and his wife have been unable to conceive for the last 2 years. His wife has no reproductive problems. The patient's past medical history includes recurrent episodes of pneumonia and hearing loss since childhood. His vital signs include a temperature of 36 degrees Celsius, blood pressure of 125/80, and heart rate of 89, and a respiratory rate of 17. The physical exam reveals nasal polyp. Cardiac auscultation is significant for the point of maximal impulse displaced to the right. ECG shows right axis deviation along with positive QRS complexes in a VR lead. Which of the following is the most likely underlying cause of this patient's condition? A. Dinian arm defect. B. Disruption of transcellular chloride transport. C. Trisomy XXY. D. Trisomy XYY. This patient and his wife have been unable to conceive for the past 2 years. Considering that his wife has no reproductive problems, the patient is infertile. His past medical history includes recurrent episodes of pneumonia and hearing loss since childhood. The physical exam reveals the nasal polyps. Cardiac auscultation is significant for the point of maximum impulse displaced to the right. ECG shows right axis deviation along with positive QRX complexes in a VR lead. These latter findings are consistent with the diagnosis of dextrocardia. Dextrocardia, along with infertility, recurrent pulmonary infections, and hearing loss, is consistent with the primary ciliary dyskinesia, also known as Cartagener syndrome. Primary ciliary dyskinesia is caused by the autosomal recessive Dinian arm defect. Therefore, the correct answer is option A. Here is the slide reminding us of the clinical presentation of the primary ciliary dyskinesia. Please consider the signs and symptoms of this condition. And let's discuss now why the other options are incorrect. Option B, disruption of transcellular chloride transport, is consistent with cystic fibrosis. Although the cystic fibrosis can cause infertility and recurrent pulmonary infections, it is not associated with dextrocardia. Additionally, the patients with cystic fibrosis have gastrointestinal signs and symptoms like steatorrhea due to malabsorption. Therefore, option B is incorrect. Option C, trisomy XXY, is consistent with Klinefelter syndrome. Although Klinefelter syndrome often presents with infertility, it is not associated with dextrocardia. So option C is incorrect as well. Finally, option D, trisomy XYY, is consistent with the diagnosis of double Y male. Double Y males have normal fertility and no recurrent infections or hearing loss. This is why option D is incorrect. And that concludes our lecture on cystic fibrosis and primary ciliary dyskinesia.